Suggest we start again. Do you hear me? Do you need some extra minutes or are you okay? Thank you for putting yourself visible. Well, I guess we should start now slowly. So before I introduce Robert Masten, our colleague, who's also member of the advisory committee, I would like to say that actually this very workshop was stimulated by the fact that we had to supplement ethics questions when applying for this project. And one of the questions was, what would you do if you deal with traumatized persons? And so, of course, we historians found ourselves in a total blank position. And so we came in contact with Robert, who was advised by our colleagues. Robert is also employed at the Faculty of Arts at the Department of Psychology. And he's associate professor, he's a psychotherapist himself, and he was also dealing with special groups like soldiers who are exposed to great amount of stress and who work in crisis territory. And if you want to know something more about him, there is a CV available online. I would just like to say that maybe his lecture and lecture of Nina Mochnik will somehow coincide because Robert will mostly speak about how to approach to the traumatized persons. So maybe Robert, if you're ready to start.
Hello.
Okay. The floor is yours.
Thank you. First, I will share my PowerPoint, and I would like to say first that my topic will not be mostly how to approach those people. Yes, it will be at the end, but my intention was anyway to talk about trauma and traumatic stress in general. But since I'm not the same person with different background, I think that will not be a problem. Yeah, we will start with this. Okay.
Yeah, we see it.
Yeah, I suppose you see. So, yes, I worked almost 10 years in the military. I'm telling you that because biggest problems of soldiers working in Bosnia, Kosovo, Afghanistan was not stress so much. Especially it was not traumatic stress. It was mostly boredom. And they had in very large degree problems with their families. Many of them they divorced after the missions and so on. I mentioned that because Urshka said that these people were traumatized, but they were mostly not, in fact. That's some kind of myth, but of course in different kind of missions that will be of course different, because in this was peacekeeping or peace enforcement missions mostly. Well, which events are traumatic events? Were you talking about that? Okay. In fact, it's quite clear that situations which put in danger our lives and our close people lives, or a possibility to be injured. These are no doubt traumatic situations. But what is important to say is that there is much bigger difference in interpretation of non-traumatic situation, because these subjective interpretations could be traumatic, although the situation itself is not traumatic. And so this changes a little bit, not a little bit, this changes perspective quite a lot, because situations could be interpreted like that. And that's important to know, because traumatic situations are recognized. Mostly traumatic situations are seen very well, but interpretations which are traumatic are not seen to others. So that could be, that is important to know. Well, so how often do we experience traumatic events? What do you think? In fact, the answer is we people do experience traumatic events very, very often. The prevalence is very high. I will not give you too much data and informations, but just for yes, just some of them, maybe at least one half of people experience traumatic event in childhood. 50% people experience, so children experience traumatic events in childhood. Let's say it's till 15 years. So it's adolescence, in fact. But at least 80% people do experience traumatic events in our lifetimes. So the possibility to experience something traumatic, so with the situation which puts in danger our life, or closest people lives, or or we are in danger to be injured and so on, is very high. And these variations are also quite significant. For instance, I have some data here for Northern Ireland. Because prevalence was quite a lot related to political background in Northern Ireland, Northern Ireland in that time, and traumatic events are especially high in war regions and post-war regions. So these situations, which are, I said, quite prevalent, quite often, are mostly, it's according to one of these studies, is 42% is the death of a loved person, 17% are accidents, 16% are it is could be some kind of natural or technological disaster, or physical or sexual abuse. It is more than 6 to 7%. Childhood abuse could be sexual nature or physical, at least 3%, but could be in certain regions, certain countries, much more. So, and of course, one very problematic, especially we were instructed about that in time of Corona crisis. For instance, in first wave of Corona crisis, it was estimation was around 1% of physical violence in families. In the second wave, which are going through already now, in fact, there was 3% at least. So this hidden physical violence in families increased quite a lot, but it's difficult to measure. These are only the numbers which were given. People were prepared to share those numbers. Could be these numbers could be much higher. So and here about traumatic events themselves, I would like to mention the problem that that in fact especially problematic events are repeated traumatic events, because for instance physical violence in families here is typical example of type of trauma which is usually repeated, or combination of events. So and also all traumatic events are not same in nature in their possibility for negative effect. Those traumatic events which are done by people, especially by close people, are much more problematic. And when we are talking for the beginning about the exposure of traumatic events, it is important not to forget to secondary trauma, so-called vicarization trauma. Vicarization secondary trauma. For instance, in 90s in Slovenia, we had and all, especially in 90s when there were West Balkan wars, where, let's say, you know better probably, 140,000 people were killed. For instance, in Sarajevo, 14,000 people. So, and in general, in 90s, it was regarding different locations, refugee crisis, very special, because in that time there was estimated in 1992 that there were altogether 18 millions of refugees all around the world, and these refugees are somehow exporting trauma. So we come in contact with traumatized people, so we are also exposed to secondary vicarious trauma, especially those who work with that people. I had one case today in the morning when my colleague working at community health center was somehow influenced by sexual violence in family, and he reported to me that last 5 days he's not in good condition because of that. So being in contact with those people is also some kind of sign of our health, sign of our empathy. But yes, that's secondary trauma. And last but not least, I am still in contact with Slovenian working and living, who was born in Austria, Daniel Vuti. He was doing research of transgenerational transmission in Slovenian Korean families during the Nazistic terror in those times. So it is also for you historians, I would say, very interesting issue to study and to stress. So these effects are also transmissible during generations. So we see that there are very different kinds of trauma, and I would say and emphasize even more precisely that especially problematic are traumatic traumatic experiences to children, because those somehow are combined with development processes, and that can be really disastrous for children, and especially for children till 10 years, because especially those group, they have low level of autonomy. They don't understand the situations, and it's a bit better for adolescents. They are after 10, 11, 12 years in so-called abstract level of reasoning, and they are able to understand much more what's going on, but that's not enough. So it's very problematic. But children are surprisingly, or not surprisingly, doesn't matter. It's even worse if it is surprisingly that children are very often victims of different kind of traumatic experiences. It was told quite often in Corona crisis that people will be traumatized because they are not attending the school. So just few numbers again. You see that according to World Health Organization, half adolescents from 13 to 15 years are included in bullying in schools. 70 till 800,000 millions of children. So 800 millions of children live in countries where physical punishment is not forbidden in the world. So, for instance, in 2017, there were almost 400 military attacks on schools in South Sudan, 70 attacks in Syria, 20 in Yemen, and so on. For instance, in 1980, out of 80,000 of children in Sarajevo, 32 were targets of snipers. 30,000 children were targets of snipers. So half, so that means 40,000 saw the death of men, 40,000 saw one or more deaths of relatives, 20%, that's 15,000, were they witnessed massacres, and so on. Half of them, they have occupied homes, and their homes was attacked. 90% they lived in shelters, and so on. And we had at least tragically 1,600 people in Sarajevo were killed, and additional 15,000 were injured. But I will give you one example in highly developed countries, Denmark, just to emphasize that it's not only about the wars, that the level of traumatic events is very high also in such kind of countries. And these traumatic events are the death of family member, threat of violence, accidents, rape, suicidal attempt, death in family, illness, and that there are significant and quite consistent risk factors for being victim as a child. That is gender of a child, education of parents, single parent family, and exposure to more traumatic events. So that leads to higher possibility to be a victim or to develop clinically significant consequences of traumatic events. Well, I said it is trauma is defined also according to mechanism of subjective interpretation. So you probably know sayings. There are many of them, like castaways are afraid of calm sea, or who was bitten by a snake is afraid of a twisted rope, and so on. And of course, people who survive trauma, and there are quite many as we saw, they are inclined to more negative interpretation of ongoing events. And what I would like to emphasize here is that in some communities, so I am not go only to individual level, but in some communities, for instance, in highly religious communities, uh, some kind of mockery or abuse of religious symbols is perceived as much more traumatic as the possibility to be injured or to be killed. More traumatic, perceived as more traumatic, or the threat to community could be in very coherent, more, let's say, some communities which are very coherent, the threat to community itself is perceived much more dangerous and traumatic than the threat to individuals in that community. So that's different angle according which we can try to understand how important is to stress cultural, inter-individual, and other differences. So, and many of these communities, as you know, are endangered by genocide, the threat of war, discriminations like racial, gender, and political, and in the basis of sexual orientation, discriminations. So possibility is quite higher for those people that they um, experience a series of traumatic events. So till now I was talking about traumatic events themselves. But now question is, how often do people, let's say, I don't like that expression, but let's say develop clinically significant effects of traumatic uh, experiences? The answer is that relatively those clinically relevant effects are rather low. If 80% in lifetime, if the traumatic events or experience of a traumatic events, as I said, are 80 to 90% in the lifetime prevalence. For instance, PTSD is, according to one quite new European study, is 1.9%. So lifetime PTSD is, let's say, 2%, 1.9. But year prevalence, so experience or existence of PTSD in interval of 1 year is approximately 1 or 1.1%. It is quite low according to high prevalence of traumatic experiences themselves. But anyway, absolute numbers are still very high. And by the way, those who do have, well, PTSD, they usually experience at least 3 to 4 traumatic events, not only one traumatic event. So, well, I will not mention again what kind of, according to this research, what kind of events these are. But I would like to say that these absolute numbers for Slovenia, which is a tiny state, as you know, only 2 million inhabitants, that for Slovenia, that 1% of year prevalence means 2,000 individuals. For Italy, that means in year basis 600,000. For Austria, 80,000. For Croatia, 40,000 individuals. But probably in Croatia, the situation is difficult. When I was working in military, and still I have colleagues from Croatia, they were really experienced in dealing with traumatic, with individuals who had different kind of psychological problems, for instance, PTSD, which is only one of that problem. So it's good that relative numbers are small, but it's bad that absolute numbers are anyway quite high. So I must say that we are, when we are talking about PTSD, the prevalence of PTSD is consistently higher in women than in men. For instance, twice higher. I have data for European countries, for United States, and so in quite consistently, at least twice higher in women. So, as I mentioned before, in the case of Croatia, I was involved in different kind of research in some countries of Balkans, and I must say, and it is according to many other researches, that prevalence of PTSD, which is the only one problematic, clinically relevant affected traumatic experience, the only one, it's usually most widely known, but I will tell you later that there are many much more other problems. So in such kind of post-war countries, the prevalence of PTSD is much more higher, could be much higher. Well, PTSD, for instance, it is only one case, as I said, but it has global validity. Well, there were some tries to more different kind of interpretation that in some countries I have a specific handbook, if in my mind, that were Serbian handbooks of Yugoslav army. They reported that there in all countries is PTSD very known, except of Serbian army, but that's not the true. Validity of PTSD is global, although the symptoms are not same around the globe. In Western countries, it's much more significant. Suicidal ideation, guilt, embarrassment, risky behavior, amnesia, but in non-Western countries is much more emphasized. Physical symptoms are much more emphasized, social withdrawal and lower work effectiveness. So, as I was mentioning before, I was included in. I said that this prevalence of PTSD could be much higher, and so I can give you example of Kosovo. It was not a real or total clinical examination of participants in that study, but so we are talking not about PTSD, but about possibility of PTSD, but it was as high as 47%. So, and that was after 10 years, and because that means chronic PTSD, it's another form which is more problematic and it is not curable anymore. When PTSD becomes chronic, it is present forever then. So, and other research show that it stands for Balkans that PTSD is as high as 34 in average in Balkans. And as you see in Algeria, Cambodia, Ethiopia, Gaza, it's even, it's same. But as I said, it's not only about PTSD. There are unfortunately many more clinically relevant consequences of traumatic experiences. For instance, maybe it is one of more widely known examples of that. That is borderline personality disorder. Research showed that in 30% till 70% of patients, so people with borderline personality disorder, they are traumatized. So I remember one expression that borderline personality disorder is hangover of trauma. Borderline personality disorder became known and much more prevalent, and after that also much more research problem when US Army nurses came back to the United States from Vietnam, and after some years they found out that many nurses, they had symptoms of borderline personality disorder. So that's and then it's not that only if they have PTSD or borderline, it's more or less always that comorbidity is very high. So it's usually comorbidity is usually depression and substance use disorder, and also other problems, reactive psychosis and so on. So we must take into account many other problems. So and it is not just in these medical terms of diagnosis, because this diagnosis hide quite often much more than they explain the situation. Its effect on hope, its effect on normal development, especially in children and adolescents. It is a negative effect on personality growth. It's significant in problematic effect in physical health and so on. Although you don't have any diagnosis, you for sure have problems which are mostly negative. So when I'm talking to I don't know, to in fact 20,000 people with on year I don't know, or hundreds of thousands of people who has PTSD in bigger countries than Slovenia is, we should talk about their families. So it's a catastrophic effect on working on all pillars of identity, professional aspects, families. So all areas of life are terribly endangered. And families are traumatized and communities are traumatized. So that's important to say that we should not talk about, mostly we should not talk about individuals where we are talking about clinical relevant consequences of trauma. I would like to add that, as I said, for women, when I said that in women, these consequences are higher than in men, but also in children, the prevalence of PTSD is higher than in adults. And again, higher in girls than in boys. And we must take into account, we must know that adversities in childhood are related to large portion of psychopathology in childhood itself, and also in pathology which is seen in adult population, in different kind of diagnosis, but not only, as I said before, diagnosis. Additional problem is, I will tell you one example, that it's quite shocking for me, that in 25% of children and 15% of their parents in one population, they had PTSD. That's a lot. So I don't know now where it was, but it is American article here, and for only 46% of children with diagnosed PTSD, their parents seek any help. So less than half of children which had PTSD, for less than half, their parents were looking for any kind of help. That's not only professional help, but here is we are talking about non-professional help, like tell me what's wrong with my child, because if I ask my friend, tell me what's wrong, what should I do with my child because he has problems. So less than half. So and this proportion is much lower for parents itself. Only 20% of parents with PTSD looked for help for themselves, and that's a problem. And how do we people respond to trauma, to traumatic events? Well, all these lines you see here are, let's say, normal, but usually we use wrong word because resistant response is understood like, I don't know, more less prevalent, but as a very healthy response that we have in time of impact, intense high response, and then symptoms drop quite fast, and that cases we name resilient response. And also recovery response, when this drop of symptoms is not so fast, is understood as normal, but these are quite prevalent types of responses. Maybe it is not seem so good here, but you can see here that there are 4 possibilities in general. That distress is high in the time of impact of trauma, and it does not drop after time, so it stays high during the time, and that is 1/3 of people in this research. Then that is high in beginning, as I gave you example in previous slide, then drops over time, could be resilient or recovery. Then it is low in the beginning and stays low, or, and this one is especially problematic, that it is low level of symptoms at the beginning, at the time of impact of, or immediately after time of impact, but then this number of symptoms and intensity of symptoms grow during the time. And this is so-called subtype of PTSD. It is called delayed type of PTSD. So, well, and I would like to give you an example which I mentioned before, that it is important what kind of traumatic event individuals experienced. And I said, and this is example for that here, that that this response is especially problematic in the case of sexual abuse, because after 6 or 9 months, the symptoms doesn't drop, but even become higher. And that's this problem of, yeah. I would like to add that what are positive or negative factors for development of PTSD. I'm running out of time. Yes. So there are many possibilities. What can impact pathogenesis of PTSD, but most important, and that is important to know because we have possibility to impact on that too. So most important factors are social support during and immediately after the time of traumatic event and the dissociation. Other factors are also important, but most important are social support and dissociation. So, okay, I will not explain this and this because I don't have time, but I would like to conclude. Yeah. Understanding of traumatic events and especially psychopathology, which could be developed after traumatic events, it changed. So as I said, it shifted from focus on individuals to focus on a system. So we should offer support to families, to communities, and very often it was some kind of complaint that professionals in the field of mental health, they understand uh, traumatized people as helpless victims, not survivors, and that means that uh, those people, so professionals, they are over pathologizing people, which is a very good, very well grounded uh, comment. And well, we should always look at vulnerabilities, but also in protective. Also, we must stress out protective factors, and we must some kind of have some effect on these protective factors, which are so important. I will conclude with how to help to traumatize people. Uh, in any kind of destabilization which trauma represents, for sure, in one sentence, the intervention is to input some stability in different forms. So any kind of stabilization if is very important. So especially for children, response to traumatic event of their parents is much more important than traumatic event itself. Uh, Children from Dubrovnik under bombings in 90s were more, those children which are refugees in Germany were often more traumatized than those who stayed in Dubrovnik, but with appropriate feeling of security of together with their parents and so on. And one extremely important beside this, give support, offer stability. Another suggestion is that don't dig in depth, don't ask what happened too much. That is only suitable if these people would like to talk. They somehow coped with their traumatic events, and in that case it is okay to ask, because because it be some kind of could be curable for them. But if they don't establish their own safety, it's a danger. So it is so important to check first how is it with specific individuals you are talking to. So well, that's in fact in short. I dropped some things out, but that is what I decided to share with you.
Thank you, Robert. Um, Although it's quite late already and it is the last presentation, Does anyone has a question, comment, curiosity on coming from Robert's lecture? I started with a myth that the soldiers you investigated did not actually experience trauma. During your presentation, I realized that I possess many other myths in relation to psychological development, especially ones that address traumas. Uh, and I suppose that in regard to the high rate of the traumatized persons who over the 20th century lived through the wars, post-wars, uh, we as oral historians have quite a possibility to meet traumatized person. Uh, Okay, one thing is very interesting, and I think it also has to do with empathic approach as oral historians. So we shouldn't ask too much if a person is describing traumatic events. But do you have any other suggestions or um, ideas how to deal
Yes.
with traumatized people?
Also, Urshka Lampe asked here in chat, I see the question, advice to the researcher how to approach people who have been exposed to traumatic events. Uh, well, I would like to say that traumatized people, they have a lot to say. They have stories to say. But it is usually like that we avoid negative feelings, that we avoid things which are painful. And as I said, my advice is let them opportunity to tell their stories. But you should check first what is the condition. Immediately after the traumatic event, all people are destabilized. That is not time to ask questions. But after many years, it is of course time to ask questions, but still, as I said, trauma or the traumatic consequences of pathology of traumatic experiences could last a whole life. And if you are talking with that kind of individuals, you should check, just ask simply if it is very painful or problematic to talk about that. If they said, no, I would like to talk, then it is okay. But if they said, because what let's say professionals, also psychologists must do is to support their autonomy, their personal sovereignty. So if we say, no, it is dangerous for you to talk, then we put that person in situation of helpless victim. So we must give opportunity to decide for themselves. But it is important to ask. So I would say, ask rather twice than only once if they would like to talk. Uh, and if they said no, that is appropriate to stop with that. But because this story is a kind of therapy, could be kind of therapy also. And therapy for borderline people is, for instance, to make their traumatized narrative more coherent. Yeah, and so I would conclude with this answer that be aware of possible iatrogenic effects of your questions, but be aware also that these stories they tell could be also healthy for them. But check first before you go in depth. That I would say is most important. And check as many times as needed.
Okay, thank
Yeah.
you.
And these ethical issues you mentioned, Urshka, were related if what happened if we make a mistake, if we go too much in depth, and then we're not able any more to stabilize that person. In that's different case then we need to ask for help for of professional. uh, we should give informations, numbers, and so on.
Mhm. Is anybody asking something? I know it is quite late. I have another curiosity. If you can shortly address, because I noticed that everything that is connected to psychology is rather complicated. And both you and Nena emphasize that you put everything in short. But I'm curious about because you were talking that psychological picture varies through time, through space. So in certain places, in certain cultures, people respond differently to the same situation, let's say. But is it possible that also that these psychological responses develop over time? So I have an impression that we are oversensible now in comparison to, I don't know, 100 years ago. Can you add something to it, either?
No, I would say again that uh, we people in all cultures and all times to that threat we react same. For
I
instance,
believe.
yeah, if our life is threatened, then we react same matter. But the biggest difference is how we react to those things which are not so dangerous, but we could interpret those situations as very dangerous anyway. That the second part is more variable, but we people react like animals because it is not related to our newest brain structures. It's related to sub-brain structures, to reptilian structures. We to the great danger we react instinctively. So uh, that's, for instance, long-term memory uh, and anticipation of future is inclined to be positive. We remember positive things, and we wish usually for future positive things. But short-time memory is uh, preference is negative things because it is safe. It's more safely. So if we are talking about acute danger, we focus on the negative aspects, on possible threats for us and our community. So yeah, but this second part, as I said, interpretations, those really are very different, and they are more related to different kind of cultures and so on.
Okay, thank you. So I'm asking for the last time. Does anyone want to have a word? Okay, then I suggest that we close this day. I wish you a nice afternoon, and I hope we meet together tomorrow together at 9 with the second set of lectures connected to or related to border realities. So thank you for your attention. Thank you for listening. And see you tomorrow then. Bye.
Bye, goodbye.